paper is a consequence of an invitation of David Tackett, as many other things that happen normally. Or when David asked me to write something for the 75 years of the International Journal about interpretation, formulation of the interpretation. And then I began to say that in the verbal communication, interpretation has two sides. One is how you formulate the interpretation in your mind. The other thing is how you word interpretation with the patient. And the wording of the interpretation has a lot of things to do with how you conceive human communication. My interest in this question was the opportunity to say that really in the history of psychoanalysis, even if Freud said that psychoanalysis is a talking cure, little attention was paid to what means talking. And overall, there are a lot of things in linguistics that could inform better this issue. And for communication in this case was important for me, a patient that I had that was a musician, quasi-psychotic, but with a way of communicating very interesting, because it was a mix of words and music. Sometimes he spoke in music. I have an association, I have a melody like this, and he sing the melody. And that was an experience that I tried to explain. The other thing that was important for me in that paper, and that was the origin of the title, Transformations, was how you produce a transformation in your work with the patient, and how you could study the progress, the process in analysis, if there is or not a process, looking exclusively at linguistic issues in the discourse of the patient. The case of this patient was interesting because the psychotic crisis arrived when the patient was thinking about words that had not specifically a semantic meaning, but are within linguistics we call shifters or the deictics, and are words that have no easy connections. For example, when we say in analysis here and now means that you must say something where is here and where is now. If not, the word is completely abstract. Then, when he arrived to this kind of situations, he was desperate and he began to become more and more anxious and more psychotic. He was unable to use pronouns, for example, and he never named my name in analysis. Then one of the sessions I reproduced in the text was a session where he was able to use pronouns, you, me, and so on, and also to say, oh, Dr. Canestri, what a silence in my head. Then that for me was a sign of progress and a sign of change. A transformation was produced, and the process could be studied in this way. Yes, this is one of the main arguments of contemporary psychoanalysis. Yes, I think we must introduce some specific technical changes, not in the common sense of having analysis face-to-face, for example, or something like that. I don't agree with that. But I think that we must be very aware of many bits of communication that are not exactly semantic, coming from the patient, and trying to work on that. In that sense, trying to work with something that is the most unknown thing is coming from the patient. when in this case, but there are many others that I could quote, the patient says, "Oh, silence in my head." And he is doing this. There are some reference that silence now means now, here and now with you. But this is not explicit. And in my head implies that is his head, but also my head and something else. And the gesture is not indifferent. Then you must try to find a way to interpret all that all together. And after that, the patient make a gesture as putting his hands on the piano. And he was also a pianist and not only a compositor. And the imagine that he want to contain something in an object and in a field that is his field and his way of expressing his affects. Then the interpretation must have to do with that. Then I think that this is very important when you are having work with very ill, severe patients, that there are ways of communicating that you must try to understand. It's not necessary to be face-to-face. It's not necessary to be not on the couch or to try to reduce the sessions and so on. This is not important. What is important if you are trying to do your best to understand a very primitive way of communication. And in that sense, obviously children are a good way of understand many things that we are unable to understand, but also animals, if you want. Because when I was trained, for example, the idea was if the patient is doing a gesture or is doing something that is physically, or a lady or a man are doing something with the legs and you think that is an equivalent of masturbation, one of the recommendations was don't speak about that because that could provoke a very paranoid reaction in the patient. I don't think so. I think that you can do it. The question is how you do it, and which kind of reaction provoked depends on how you are saying that. In the case I was supervising yesterday, if the patient is clearly with the transference lab with the analyst, a woman, and she makes an interpretation about, are you aware that you're asking to lingering with me? Lingering has a very strong meaning. It's related with a lot of things and has a high affective content. Then you must be aware of that you also are not using words by case. You are using words that could be very effective and could be very potent in terms of intensity of affect. Then my idea also is that we were constrained by technique with the patient on the couch to eliminate the body in psychoanalysis. Then you must find a way to reintroduce the body in the discourse. A famous linguist, Roland Barthes, he said, when you pass from the verbal communication to the text, you lost something essential, that is the body. The body is not speaking in the text. But the body is speaking in analysis, even if we don't speak specifically on that. Because in fact, we are not completely aware many times of what we are saying and doing. But if you become aware of that, for example, the use of lingering, perhaps you can talk about it with your patient. there are different kinds of self-disclosure, you know. If you say lingering, you are doing a self-disclosure. You are saying something that also for you, for the analyst in that situation, has some special signification. Then, if you discover that, and you discover that that provokes a reaction in the patient, you could talk about that explicitly. That means a kind of self-disclosure, I said, because you are transforming also what was apparently a neutral interpretation in something that produced an effect and is related with what was happening between you and the patient at that time. My idea is to write a book on interpretation when I have time. That is very difficult. I will reproduce this text, but I will try to explain other things that are related with this, and I thought of the paper. But the essential issues of the paper will be the same, and the example overall, because I think it's a special example that allows us to think many of these things. I had another musician, and I wrote another paper on his position that I think also was interesting. The question is not in English, it's in French, but he's a man who had a different way of communicating that was by his gestures. He was a director of orchestra and was passionate to try to understand what he was saying with his hands, how he was trying to explain the music with gestures. I wrote about that. First of all, I will speak obviously about implicit theories in interpretation, because implicit theories also allow to understand why you are doing an interpretation in that way, and which are the ideas you have on therapeutic action on the patient. What do you want to do with your patient? In what sense do you want to produce a transformation? I will work on Bayonian ideas of transformation related with a way of epistemological position of many analysts that are more and more relativists about reality. I'm not a relativist in that sense, and I try to defend the possibility of pitching a piece of reality in your work. That's why I think it's not the same one interpretation on the other. I would like to develop this kind of Bayonian idea of invariant that I think is important. That means that when a painter paints a field of poppies, as Bion says, it's important to recognize that this is a field of poppies, in the sense that you can paint it as you want, but something must remind you that this is a field of poppies. In terms of analysis, I think that the patient must recognize that what you are saying has something to do with him, not just because he will accept any kind of things you will say, but because there is something that essentially is related with himself or herself. And I don't think that it's the same to do an interpretation of this or another completely different. And I don't think that the main issue of the interpretation is to be related with what is happening in the field. Because human communication is bipolar. That means that if you and me, we were talking, we were looking at ourselves, and we are looking at our gestures, and there is affect running between. This is common to everybody. This has nothing to do with psychoanalysis. Then if you are doing all the time interpretations about what is happening between you and me, this changes nothing in terms of transformation. You must say something that is related with the unconscious of the patient, And the unconscious of the patient, as Freud said, curiously related with the body and also with the dream. Freud used a word in German that is Fremde, is the most strange thing, unfamiliar thing you have. And he said that your body and your dreams is the most unfamiliar thing you have in your life. And he said that in the project many years before beginning, what he called the Fremdkörper, the body that is strange for each one. And also the dream is strange. Then the unconscious is the unknown, and you must work on that. Not to transform that in something that is known, but to produce a transformation. There are many things that I could add to that, if I have time, but I don't have time. When I was training in medicine, and I arrived for the first time to histology, and they gave me a microscope and put a piece of any kind of human material, saying, tell me what's that? What do you see in that situation? Just a piece of light. You don't understand nothing. Then you must be aware that there is a theory of optics that explains the microscope, and you must know how is the essential form of a tissue and which kind of tissue it is. Then you introduce a lot of information and theory in what you are looking at. And then after it's very easy to say, that's a piece of brain. But that is not the empirical material. The empirical material is full of interpretation and theory. Then you cannot have a common ground. If you don't believe, for example, in projective identification, you don't identify the projective identification in the clinical material. It's very easy to understand that. And if you discuss with someone clinical material, this is rather evident from the very beginning. Then I defend the difference between theories. And what is worst, I think that there are some theories that are better than others. But we must not say that normally. There are different criteria. What I wrote in the last book was you could also apply what is called a Bayesian theorem about probability and study how a hypothesis you are putting at the beginning increases knowledge at the end or not. If increases knowledge, you have the right to continue to try other possibilities. If it does not increase anything, you can abandon it. Then there are many ways of testing theories. It's not true that you cannot test a theory. Psychoanalysts are afraid of testing theories because that means that they must abandon some theories that they love very much. Because, once talking with Andre Green, I said, tell me, Andre, why analysts, we feel so bad when someone says us, oh, in analyzing clinical material, this is wrong. But it's very easy because theories are related with your internal world and is your ideology and are your way of understanding the world. And if you tell to analyst this is not true or this is wrong, you are saying to him you are stupid or you are crazy. And this is not nice. Nobody accepts that very easily. And he was speaking about himself, if you want. The death mother is, in a sense, the history of Andre, his infancy and his relationship with his mother. That's normal. We work like that because our heads we are using our experience and our heads. It's inevitable. But there is a possibility of make a step to understand what we are doing. That was the intention of implicit theories. If you want, there are two sides of this question. One is to explore these issues for the analyst, for doing that the analyst could understand better what he or she is doing. And the other thing is if the election of a way of doing is a better election for the patient or not. In that sense, I don't agree exactly, completely with David saying that we could be completely neutral considering different clinical works of different analysts. Each one of us has a preference that is very clear. And I think that there is some amount of reality in what we are interpreting, or if you want beyond call an invariant, that must be present, and not all the interpretations are the same. For me, there are some interpretations that are better.